Hello, everybody, and welcome to the referral, pre-assessment, and assessment section for our class. What we're going to be learning about in this particular section is listed here, some of which we will go over in this lecture and things that we will just continue to learn as the trimester unfolds. Tonight, what we're going to look at, or today, depending on whenever you're listening to the lecture, are those pre-referral steps, kind of how does that take place, what you need to do in a pre-assessment, various parts of an assessment, and then we're going to look at identifying and eliminating our own biases, especially when doing assessments and report writing. Then we're going to look at what is needed for report writing, and then I'm going to give you a few tips and tricks on things that I've just learned along the years on things that help when you are doing an assessment, particularly with children, but probably is pretty effective with adults as well. So, principles of a good assessment. So, a good assessment is really thorough. We want to make sure that in an assessment, we're looking at the person who we are assessing in their totality, that we're not reducing them to just a number or a couple of numbers, but we're actually looking at the whole person. What is going on in their life? What happened before? What's going to happen after this assessment? What are our plans? How are we going to be helping this particular client? And making sure that we're always looking at the person in whole. So never getting so blinded by the tree that we forget we're standing in a forest. So you'll hear me say this a lot, to always just take a step back. Take a step back and make sure you're seeing the bigger picture. When we're doing assessments, it's also critical that they are valid and reliable. And we'll just go into a further discussion with that in this particular lecture. We want to make sure that we're tailoring to our individual clients. So making sure that we're not just picking an assessment just because we know that it tests for articulation, but a test that we know is going to be effective for this client. And we want to make sure that we're not pigeonholing ourselves into one particular modality, but really looking at a variety of assessments, including interviews, reviewing those case histories, both formal and informal testing. Dynamic testing is really, really critical, and we're going to learn about that in this course as well. And then just being able, when possible, to do client observations. So just kind of an overview of what's going to make a good assessment. So how does a client even come to us? So referrals come in lots of different ways. So it's not a one size fits all here. If you're in a school system, the referral might come from a teacher, a parent, it might come from another professional. So maybe the child is seeing someone else, maybe the math specialist, or someone who's just seeing that the child is struggling. But in other facilities, so maybe a private practice, a parent might come to you because the pediatrician suggested it, or they might come to you because a teacher suggested, but maybe they're not meeting eligibility criteria in the public school. In a medical facility, of course, you're going to see patients for a variety of reasons, such as traumatic brain injuries from a car accident, sporting incidents, from a stroke. You might get a patient from somewhere else. If you're in a skilled nursing facility or a SNF, that patient could be coming from the hospital, and so that's how they're going to get on your caseload. A lot of the times, if you're working in an ER, it's just part of protocol. You're just going to be part of the team that's going to assess. So doing bedside swallows and checking cognition. And so referrals come to us in loads of different ways. And you're always seeing that there are a lot of players in this particular case when it comes to getting our referrals for our clients. So once we get that referral, pre-assessment is going to be really, really critical. So there are lots of questions that we could ask. Here are just some common ones that are used in communication disorders. And this is a very brief list, but there are lots of other questions that you would want to ask. So collecting something like a case history, which we're going to look at those in class as well. You'd want a case history to be able to say, okay, what happened before you came to me? What was the reason why you were referred to me? And asking lots of questions before we even get to that assessment process, because what we're looking for is, what is the exact issue that's going on here, and how am I going to be able to assess critically to be able to help you, to look at you as a whole, to be able to help find out what's going on. I also want to know how you feel. I want to know how this is affecting you and your family and everyone around you. So it's really, really critical that we're asking a lot of really, really important and detailed questions. We're also going to be getting information from lots of other professionals. Sometimes you can't even do an assessment unless you have certain information. So you might need information from an ENT, and that might have to come prior to you starting an assessment. But you might also look at things from an audiologist or maybe a dentist. So if you're looking at an articulation disorder and a child has severe differences in their mouth on what's going on, you might have to actually think about the dentistry or the orthodontist work that needs to be done prior to us even getting in there to do anything, because that's really going to impact the child's ability to speak clearly. You might also have to get information from teachers or other specialists. You might need to think about a physical therapist or an occupational therapist, especially PT and OT. If you're looking at doing an AAC assessment, we have to know what are the physical constraints, what are their gross motor skills, what are their fine motor skills, and how is that really going to impact? Because if we have a gross motor or fine motor skill impact that's hindering the child to be able to access their device, an assessment from us is not going to be valid if it's not a language barrier, it's a physical barrier. It's really, really critical that we're looking at what information do I need from another professional before I even do my job, right? So before I even get in there, what do I need to know? The information can be really helpful with knowing what's the etiology of the disorder, especially in our adult clients. If they're coming from a hospital or another medical facility, this will be really helpful for us to know, like, okay, what happened prior to you coming to me? What was the incident that occurred, and what are you dealing with? And kind of what other treatments maybe did you undergo before I'm doing my assessment? We need to look at social and educational. The family is super, super critical, from young children all the way up through adults. The family oftentimes can give us a lot of really great information, and they really are a great ally to have. So we always want to make sure that we're asking the family for their opinions. Especially with younger children and even adults, we do want to ask about that treatment history and how this, like, what were the effects of the treatment. So with our little kids, if they're being referred to us, maybe from one private practice to another, what was going on before they came to us, and why now are they coming to us, and how are we going to be able to help? So these are really important that you ask. If, for example, again, if you have an AAC user, let's say a kid comes to your caseload and they come with an AAC already, asking those really important questions. Was there actually an assessment that occurred for this particular device to be chosen? Or was this device chosen out of convenience because the family wanted it, the therapist wanted it, it was cheaper, or et cetera, et cetera. So we need to know, what is the treatment history? What happened in assessments prior to them coming to us, and kind of helping them move through that. So we want to look at prognostic implications and also the treatment options and other alternatives. So just really, really critical that we think about these things for sure. Motivational interviewing is absolutely critical. So motivational interviewing with our clients, we must do, because this is going to be our person-centered approach where we're asking the client to interact with us. It's a very client-centered approach where we're saying, we want to understand your perspective, and we're making sure that we are even keeping ourselves in check in understanding that this is a collaborative relationship, that we don't have total control, that our client needs to be a part of this process as well. So we need to be asking open-ended questions to allow us to gather really important information and build that rapport with the client. And so we want to be making sure that we're affirming our client, looking at their strengths, boosting their confidence, and really utilizing active listening skills and reflecting back on what the client says. So the client might say something, and what does that look like, right? So the client says something, and you say, what I heard was this. Can you confirm this is what I heard, that I understood correctly? And we're always asking, like, did I understand that correctly? Am I seeing things from your perspective? And really encourage our client to believe in their own abilities, that their change is possible, that they can be successful, that there's progress that can be done. because we want to be able to help our clients when we're interviewing them, when we're getting these questions gathered. So motivational interviewing is something that you could even just practice with a colleague or with a friend or someone that you could say, hey, can we just practice this skill where I can ask you open-ended questions, and doing our best to never ask those yes, no, or one response answer questions, right? So if the socially appropriate response is one or two answers, these are probably not the types of questions you want to be having in a pre-assessment. It's not really going to help you too much, of course, unless you're asking birthdays, basic information, milestones for a child. But when we really need to get into the meat of it, those are the kind of things we do want to avoid. All right, so let's get into the actual assessment itself. So we have to think about the quality. So we've done all these really great questions. Now we've decided, okay, I have a good understanding of what this client needs. I think we're in good shape. I'm going to now move into picking the right assessment for my client. So the first thing we want to think about is quality. And psychometric principles actually say when we're about to pick an assessment, we have to think about the validity, the reliability, and the standardization of these tests that we're picking. And we're going to go into each one of these. So what does it mean for a test to be valid? So I need to make sure that every test that I'm picking is a valid test. That means that it assesses the skills that it claims to assess. So when I look at when I'm looking at the manual, it says we're going to assess the domains of receptive and expressive language, and you need to make sure that the content of the test is representative of those domains that it's claiming to represent. So if it's missing something, if it's not actually measuring the things that it's claiming to measure, this is not a valid test. So we want to make sure that these criteria are being met and it is congruent along the way, right? So that we're saying like, yes, I need this information. This test says this is what it collects. Okay, it is a valid test. I have checked the test. This is correct. And tests have to be compared to an established standard. So something like intelligence or an IQ. And there's a lot of thoughts on taking IQ and measuring IQ, and some issues with it not necessarily being an equitable way of measuring a child's intelligibility. But we want to think about an already established standard. Think about it just the way IQ is just an already established standard. So we want to think about the validity of our test as something like that, an established standard. And it's going to predict the performance in another situation or in the future as well. So is this test actually valid? Does it assess the skills that it claims to assess? So you have to ask yourself that first. Then we have to say, is the test actually reliable? So if the test was to be done over and over again, is there a stability over time? Right? So are the scores going to continue to be the same? Are the results of the test going to continue to be the same? And we're not talking about perfectly the same. We're talking about a range that is an acceptable range. And we'll talk about this when we talk about confidence intervals and when we get into actually putting our hands on tests and looking at them. In confidence intervals and looking at tests, this is something that we want to say, is it falling within this range? And we want to say, is there that rater reliability, right? So among individuals who are rating the test, so it's not just me when I'm scoring the test, this adult or this child is scoring a particular way, but then if they go off to my colleague, are they then going to perform a completely different way? Well, that doesn't make this a reliable test, right? This would make this non-reliable. And results are consistent even with yourself. So that interrelatable reliability, and then the intra-relatable reliability as well. So are they different from one person to the next? So just making sure that the test is reliable as well. And then finally, this standardization. So, and this is only for formal tests. So do keep that in mind. When we're talking about informal tests, they have a completely different set of standards. So we're just talking about formalized tests, standardized tests. And we have to think about, is it talking about the purpose, and is the age range correct? Is the test constructed and developed correctly? Think about the scoring procedure and the sample that they took. So if you're trying to get a standardized score for a client, but you're looking at a test that the type of culture or background that client comes from, they were not present for the standardization of this test, this particular test might not be the best option for that client. Or let's say that you have a very unique cultural background and there just isn't a standardized test available that actually included the client that you're going to be looking at. This is something that you have to take into consideration when you're doing your interpretations, when you're doing your report, saying, here is how the client scored. However, it is of note that my client's cultural background is not represented in the sample group, nor are there any other tests that have my client's sample group. So you do have to make those clinical decisions and saying, is this test reliable and valid, but also is it standardized and who is it standardized? If it's not being standardized on a large range of clients, so it doesn't have a lot of cultural backgrounds, it doesn't have a lot of ethnicities that are represented, this particular test is really going to be limited. So I know we don't love reading manuals. They're kind of boring. We don't love reading them. But it's really critical that we look at the manual prior to administering a test because, again, if this test was only standardized on a small ratio of the US and your child is not represented, so maybe they're only this particular test only looked at children in the South, but you're living in the Northeast or you're living in the Northwest or anywhere else in the country, right? That's not necessarily going to be representative of your child. So it's really, really critical. As boring as they can be, I know they can be boring, but use AI, ask AI if it's really that overwhelming, you really can't stand to read the manual. But just looking at the manual, the sections are really small in the manuals where it talks about the standardization. It tells you who are the groups that they were tested on. And it's really critical that you look at those and make sure that your client is being properly represented. So standardization should also follow a procedure. So you have to think about certain considerations. So accommodations are okay as long as they don't compromise the standardization. So let's say you have a child who needs a larger print. They need to sit in a particular way. They need to stand. You have an adult maybe who might need to take more breaks because this test is long. That's okay. Those sorts of accommodations don't modify the standardization in any way. However, if you have to modify the administration, so simplifying instructions or allowing extra time or skipping items, you may not score and provide a standardized score. So there's value in what you're finding. You can talk about what you found, but you absolutely cannot report a standardized score. And I cannot emphasize that enough. It's okay to make modifications if that's really what you need, if that's really what your client needs. However, you cannot report that as a standard score. Excuse me. And you have to write in your report everything that you did that modified that test to help the client get through that test. Whether it's a child, an adolescent, an adult, it doesn't matter. Any way that you change the directions or any way that you change how that test is supposed to be administered must be reported, and it immediately eliminates the ability to do a standardized score. So please make sure that if you need to do that, that you are keeping track of every single modification that you have made, that you are keeping track of everything you have done. All right. Accommodations, fine. Larger print, fine. Modifications are fine, but you cannot report the standard scores. All right, hopefully that's clear. We can definitely chat about that some more. So let's talk about standard scores. And a lot of times people look at scores and they think, oh gosh, it's research all over again, and this is too hard, and I don't want to do this. But I'm hoping this slide kind of just breaks things down for you. So let's go through these 8 things. Let's kind of talk about them. So a raw score is great. A raw score is how we're going to get to a standard score, correct or incorrect. But raw scores mean nothing. I can't emphasize that enough. Let me say it again. Raw scores mean nothing, because one test you might have a raw score of a 50, one test you might have a raw score of a 12, one test you might have a raw score of a 2. That means nothing until it is standardized. Raw scores can be helpful if we have done those major modifications, and then maybe 6 months later we're giving the test again with the same major modification. So we can't report a standard score, but we can look at the raw scores. That can help for clients like that. But in general, raw scores mean nothing, and reporting them is completely useless. A standard score, we're going to take the raw score, we're going to convert that to a standard score, and I'm going to show you how to do that. You're going to go through tables and charts and learn all that kind of thing. A standard score reflects the performance of your client, adult, adolescent, or child, compared to the average and normal distribution. So we're going to say, okay, here we have the bell curve, and we're going to look at a bell curve. We're going to talk about the bell curve extensively. But we look at that bell curve and we say, here's where the average population of this particular age range is falling. And here's where my client is falling, above, below, or within the average. So that's what your standard score is going to say. And we're going to talk about standard scores and kind of how important those are and making sure that we understand those correctly. Then we have what's called a standard deviation. So this is how far away from the norm our client is deviating. So above or below. So we consider average, you've got your average, which is that kind of middle ground. You've got above average, which is going to be above everybody. Below average is going to be below your age match peers. So 1.5 to 2 standard deviations below the mean is considered significantly below average. And so we're going to talk about that when we look at those standard scores and we see our clients falling below. Are we saying, is it 1 standard deviation below? Is it 1.5? Is it 2? And that's going to help us make that clinical decision on how we're going to move forward. Our scaled scores are going to be compared to the normative data, but they don't necessarily follow a normal distribution. So you will see in a test like the SELF how there's scaled scores that are present. And so it does have a normative sample, but they're not totally the same as our standard scores. Z-scores are not talked about as much, but they are compared to the normative sample, and they do tell us how different a test taker score is from the average. I have this there. Again, I wanted you to have the information, but we don't look at Z-scores very often in very many tests, but I just wanted you to know it, to have it there. Percentile ranks are good in some cases, and we'll talk about it more in a case where we'll discuss maybe why a percentile rank would be good or maybe why we wouldn't want to report a percentile rank. But it's really important that we use this term correctly. So please make note of this term right here, percentile. And we're not calling a percentage or percent. We're always talking about the percentile rank. So where are they scoring, again, compared to their age match peers? Confidence intervals, we kind of talked about a little bit, but this is the degree of certainty that we might have. So I'm going to say I am 95% certain that if I gave this test again, that this particular client would score in this particular range. And we'll see these confidence intervals, we find these confidence intervals, and we'll put them on our protocols as well. And then a test age equivalency is available for some tests, mostly for our younger children and even our high schoolers as well. You're not going to see them on your adult tests. But what we're looking at is we're saying, how are they compared? So in a particular age range or even a grade range, we're saying the scores that they're getting right now indicate a child who is 5 years and 6 months, or indicate a kid who is in 7th grade in the 4th month. So those are the test age and grade equivalencies. And then there is a code of fair ethics, or fair testing. So we want to make sure that we're always following this code. So there's this committee that basically says that we need to develop tests appropriately. We're selecting them, administering, reporting, interpreting, that we're doing this all correctly. And this is your ethics, this is your integrity. And then informing the test takers about what's going to happen and then reporting those results as well. Now, basals and ceilings are going to be our starting points and our ending points of tests. So this is only going to be your basic introductions to basals and ceilings, and then we're going to go into this in more detail. But I want you to have a very foundational understanding. I want you to think about a basal as the basement and think of the baseline. So what is the lowest number in that test that a client needs to go to? And then the endpoint, the ceiling, so the highest or the top. So the last question that our client can possibly answer that they can get right. So baselines and ceilings. So your basement and the top. And we're going to go through this. We're going to learn about this in class. I'm going to show you some videos. We're going to learn how to find basals and ceilings. But I just wanted you to have introduction of this in your assessment, that every assessment has basals and every assessment has ceilings. Well, let me rephrase. There are some assessments that you have to give the assessment in its entirety. There are no ceilings, but many tests that we're going to have are going to have very specific instructions that say this is the basal, this is the lowest you have to go for this client, and this is the ceiling. This is the highest you can go for this client. Okay, we're going to stop here for the recordings so your recordings aren't too long. So hopefully you'll be able to kind of digest that, look over those, take some notes, and we'll talk about that more in class.